Good morning, Dr. Khan. If you're ready, you can start sharing.
Good morning. Let me go ahead and get that on the screen. Thank you so much for having me. Can you see the correct screen?
Yep, it looks good.
Awesome.
All right, well, let's get started. Good morning, everyone. Welcome to OBGYN Grand Rounds. In just a minute, I'm going to ask Dr. Ananth to introduce our Grand Round speaker. But in the meantime, with regard to attendance, we'll be taking attendance for department purposes at 8:10. If your name is displayed clearly, then we would give you full credit for attendance. The CME code will be distributed via the email system later on in the hour. And with that, Dr. Ananth, are you ready to introduce our speaker?
Yes, I am. Hope everyone can hear me. Good morning, everyone. I'm delighted to introduce our Grand Round speaker today, Dr. Sadiya Khan. He is the Magerstat Professor of Cardiovascular Epidemiology and also an Associate Professor of Medicine, Preventive Medicine, and Medical Social Sciences. He holds the distinguished title of as the inaugural director of the Center for Population Science and Aging and is a preventive cardiologist at Northwestern University's Feinberg School of Medicine. Dr. Khan's clinical expertise and research focus on epidemiology, risk prediction, and risk-based prevention of cardiovascular disease, with a particular emphasis on women's health. What has impressed me the most about Dr. Khan's academic career is her incredible NIH and American Heart Association funded grants, not one or two, but several. She's an incredibly prolific publisher. She has over 320 peer-reviewed scientific research manuscripts published in leading medical journals. And her latest H index, which I looked up this morning, was 48. Her original science has been highlighted by the American Heart Association as among the top advances in heart disease research for 5 consecutive years. She is an associate editor of JAMA Cardiology and serves in key leadership positions within the American Heart Association and the American College of Cardiology, including as a chair of the American Heart Association's working group that developed the PREVENT equations, and as a member of AHA's Joint Committee for Clinical Practice Guidelines. When I invited Dr. Khan to come and give a talk to us, I was very particularly interested in listening to her talk about women's health issues, particularly around the peripartum period. So with that, please join me in welcoming Dr. Khan on her to listen to a talk entitled A Window of Opportunity in the Peripartum Period to Improve Cardiovascular Health. Dr. Khan, thank you very much for accepting our invitation, and I'm really looking forward to listening to your talk.
Dr. Anand, thank you so much for that very, very kind and generous introduction. It's really a pleasure and a privilege to be here. I think these multidisciplinary conversations are so important, and I'm looking forward to the conversation that follows some of this discussion. I have no conflicts of interest in grant funding shown here. I wanted to start with a case presentation that is probably very familiar to many of you, but on the cardiology side, somewhat infrequently seen, but perhaps as we go through this, some of the conversation should be, how do we better transition some of these patients? This was a patient I was asked to consult on, who was 27, had had an uncomplicated delivery, and 5 days postpartum had acute shortness of breath, was hypertensive, fluid overloaded, had pulmonary edema on her chest radiograph, and exam consistent with fluid overload. Her BNP was elevated, her troponin. I'm not sure if you guys have switched to that high sensitivity troponin, but this was back in the day when we were still using our regular troponin. 2.5 was very elevated as well. We got an echocardiogram, and the images shown here show that overall, in this kind of four-chamber view where we're looking at the left ventricle and the right ventricle, show reasonably good pumping function, and her overall ejection fraction was normal. But when we zero in, there's this hypokinesis. There's a little bit of dragging here on that inferolateral side that presumably is due to the hypertension. But it sets up this question of, is that an early sign of somebody that is at risk for developing heart failure, even if this isn't what we are most scared about when we're getting an echo in this immediate period of peripartum cardiomyopathy. And so I think this case really sets up some of what I have become very interested in. Is she asked me, what does this mean for me, both in the short term and the long term? And perhaps we have some better data for the short term, but I think the long term is really important. And as Dr. Anand alluded to, some of what we're hoping to better understand with our epidemiologic data and how we can inform her risk. But more importantly, how do we then actually provide her treatment recommendations, and what are the evidence-based strategies that exist to reduce her risk in this immediate period when she's connected with care, and how do we keep her connected for the long term? Three key objectives that hopefully we'll cover in the next 40 minutes or so before our conversation, that I'm sure are very familiar to many of you in terms of focusing on the peripartum period for cardiovascular disease risk. Go over a little bit of the epidemiology and think about how that frames the drivers of these trends. And then third, talk about cardiovascular health promotion and what are some opportunities, and perhaps where is there the most potential to have benefit. So if we get started, I always like to start with this overarching framework for the female life course, and many of us are very comfortable kind of zeroing in on this reproductive life course period, which is really demarcated by the beginning of menarche and concludes with menopause, with one or multiple pregnancies in between. And I think if we break it up into life periods based on pregnancy as that centering period, we can really define pre-pregnancy, pregnancy, and postpartum as these key periods within the peripartum window, the lens that we want to use to perhaps think about cardiovascular risk, in addition to, of course, obstetrical conditions as well. From the life course perspective of pregnancy and postpartum, oftentimes in that short-term period, many of the things that you're all familiar with and far more experienced than I am in terms of thinking about maternal morbidity, mortality, adverse pregnancy outcomes, ICU is really happening in that pregnancy and early postpartum period. And then the long term is this perhaps nebulous cardiovascular disease risk that may happen up to decades later. But how do we understand and use the pregnancy period or peripartum period to consider that? I think this framework is one that is really in the last probably 10 or 15 years become very, very prominent in terms of understanding pregnancy as this stress test. Cardiologists love ordering stress tests, so we think that this is something that that resonates with people in terms of thinking about the physiologic stresses of pregnancy and how adverse pregnancy outcomes could be considered a failed stress test, leading to this risk for overt CVD. But I think one of the challenges that we have is understanding what that risk is. And there have been some nice studies that have tried to start looking at this with all the caveats of retrospective data being in terms of self-recall. So I think this paper in JACC, which was published probably 4 or 5 years ago now, asked the question in the UK Biobank. So this is a large sample of over 200,000 women that were recruited in their 50s, so the mean age was 57, and then retrospectively asked, had they ever had a hypertensive disorder of pregnancy? And about 1% did report that. So I think many of us would feel that this is probably a underestimate and may have reporting bias. But nevertheless, when the investigators looked at the association with long-term follow-up of cardiovascular disease, so considering that then they had data on cardiovascular outcomes into the 60s, they saw these consistent associations with multiple types of cardiovascular conditions, so coronary disease, heart failure. I think we're really familiar with those, but interestingly, aortic stenosis and mitral regurgitation, valvular diseases that we traditionally see in older age groups. And so seeing this elevated relative risk, even in younger women, suggested that there was an overall, perhaps aging profile happening among individuals who had HDP or reported HDP in this condition. I think this is further emphasized when we look at heart failure and break it down. So the Women's Health Initiative, which is a US-based cohort of over 10,000 women, here we saw a self-report of about 7%. These were also retrospectively surveyed when the median age was 60, and then over 20 years of follow-up were assessed for heart failure. But I thought the interesting thing here was they looked at the two subtypes of heart failure, both preserved ejection fraction or HEF and reduced ejection fraction or HEF-ref. And the interesting thing was that the associations were really consistent for the preserved ejection fraction subtype of heart failure, which we again typically think of as an aging phenotype. And so seeing it happen perhaps a little bit earlier and more higher risk among women who reported HDP suggests a more holistic aging profile may be happening. Many of the studies have focused on HDP, but we know that there are many other associations between adverse pregnancy outcomes and long-term risk of CVD. I think this is a really nice study from the Swedish National Data Set where they have linked all of their births in the country to long-term CVD outcomes that show a really consistent pattern. And I think the thing that I like the most about this paper, in addition to the large sample size of over 2 million women that they had the opportunity to follow for up to 20 to 40 years, was that no matter which adverse pregnancy outcome they looked at between preterm delivery, SGA, preeclampsia, gestational diabetes, they saw a very consistent pattern with the greatest relative risk in the early period, and then some degradation of that risk with longer term follow-up. They also looked at the additive risk of multiple adverse pregnancy outcomes, and I thought this was interesting in that there's a synergistic or increased risk for ischemic heart disease that they showed when there was a preterm preeclampsia or preterm gestational diabetes, which I think suggests the severity perhaps of the APO itself, but it would be interesting to think about what are the different potential causal pathways by which that might occur. So I don't think it's up for debate that there's higher risk for CVD, but I do think one of the questions that we fundamentally need a better understanding of in order to prevent that risk is what's the pathway through how do we better understand why people who have adverse pregnancy outcomes in one or multiple pregnancies then do go on to have higher risk for cardiovascular disease. And I think these three big buckets are a nice way to think about it. Is it the traditional risk factors? Is there something that is inherently changed in the heart structure and function or in the coronary arteries? And I think there's studies that will suggest that it is not one of these, but perhaps all of these pathways that are happening. And that's perhaps what makes this challenging in terms of trying to decompose what is the primary pathway. So in terms of risk factors, I think there's been several studies. I like this one a lot because it comes from the Nurses' Health Study where there was a very large sample of over 60,000 women and 9% had reported hypertensive disorders of pregnancy. And you see the breakdown by gestational hypertension, preeclampsia, and the overall hypertensive disorders of pregnancy. And they did a mediation analysis that said after pregnancy and through CVD, what proportion of that relationship is mediated by what we call traditional risk factors? And I think it's an interesting way to kind of consider perhaps a bit of a pathway analysis of if the majority of the risk, and we see that the proportion mediated ranges from about 57% to 84%, and with wide ranges on those confidence intervals, importantly, to think about if a large proportion of the risk is mediated by these traditional risk factors, and you see the individual ones listed there, and I definitely want to highlight the impact of chronic hypertension as we think through where are the places we want to focus our attention in prevention. You see that that a large proportion of it is mediated by traditional risk factors. So traditional risk factor screening and intervention could have a significant impact. In terms of cardiac mechanics, I think I alluded to the fact that heart failure is a really important morbidity that follows after adverse pregnancy outcomes. And is there the potential using echocardiography to perhaps see some of those signs early? And is this one of the pathways through which we could identify people who are at risk of developing heart failure and cardiovascular disease? Thought this was a really nice study, although it's a small single center study that comes from the group at Pitt. It looked at individuals who had had hypertensive disorders of pregnancy and those who hadn't. And after about 8 to 10 years from their delivery, brought them in for blood pressure and echocardiogram assessment and saw that at a mean age of 38, we had much greater remodeling and hypertension in those who had had hypertensive disorders of pregnancy. So more than half of people had developed chronic hypertension. And then if you look at these different metrics of the echocardiogram in terms of septal wall thickness, the LV wall remodeling, and E to A ratio, all of which are markers or signs of preclinical heart failure, we saw that the most adverse were in those who had kind of this double hit, had gone on from HDP to have chronic hypertension. But in the intermediate group, even if they didn't have hypertension at the time of the measurement, but had had a history of HDP, it was as bad as having current hypertension. Now, it's a small study, but I think it starts to ask the question of how much of this precedes the pregnancy and how much of this is post HDP. And I think there have been a lot of different questions in terms of what the underlying pathophysiology may be, particularly related to impaired placentation and how much of this comes into adjusting the cardiac structure and function, especially if that angiogenic imbalance that has been well described may disrupt physiologic changes of pregnancy, and then those changes actually persist postpartum. I think the kind of counterfactual question there is how much of these changes may have been present before and were also reflected in the abnormal angiogenic profile and not necessarily stimulated by it. So the third pathway that I just want to touch on is subclinical atherosclerosis. I think this is probably the area where we have the most imaging and the most data in terms of being able to assess plaque and burden in the coronary arteries. This is, again, a study from the Swedish group, and I think they have the ability to really help us better understand some of these pathways because of the fact that they have the access to national records, although downsides, of course, being that it is a largely white population, and I think we have some challenges in how we want to interpret or generalize that. In this study, they had over 10,000 people that they did coronary CTAs on, so angiograms where they had contrast and were able to look for any coronary atherosclerosis among people who had had an APO and those who didn't. And this, I think, is really helpful because on the cardiovascular side, we are becoming much more, I think, facile with having CT scan become our first line for a lot of aging and risk detection so that we can actually determine if someone has atherosclerosis. And there are, of course, downsides with radiation and other things, but I think from a research perspective, it can be a really invaluable tool in young women who often aren't going to have signs and symptoms, but we want to be able to understand their risk earlier. And you see here for any coronary atherosclerosis, there were 19% who had reported an adverse pregnancy outcome, and the presence of any coronary atherosclerosis about 30 years after the first delivery was 32% versus 28%, so about a 20% higher risk among those who had had an adverse pregnancy outcome. So these pathways, I think, are all relevant, and they may be helpful as we try to understand the evolution of risk as well as the mechanisms of risk as well. Of course, all of these pathways, I think, are preceded by what we know of as traditional risk factors coming into the pregnancy, as well as pregnancy-related risk factors, including vascular and placental dysfunction, genetic predisposition, and other, I think, contextual factors, particularly related to social determinants of health that may influence or modify the effect of these pathways. This often, to me, sets up the question then, if you have this full pathway and you know that people are progressing along a trajectory in their life and pregnancy doesn't happen in isolation, but it happens within the environment, then how much of the risk that we're seeing, even way after pregnancy was a trajectory that somebody was already on. And I really love this diagram because I think it helps to visualize this question in a really nice way of asking, is this adverse pregnancy outcome that we're identifying, or the failed stress test that we like to call it, a marker of risk that was already there, or is it a mediator and it's having some potential causal influence? So this idea that this trajectory that somebody who had an adverse pregnancy outcome where they crossed this threshold for whether their blood pressure crossed that threshold, their glucose level crossed that threshold during pregnancy, that was a reflection of the trajectory they were already in that was fundamentally different than somebody who is healthy and didn't cross that threshold. Or did it alter their trajectory and their slope following, or both? And so I think the analogy that I sometimes think could be helpful is the adverse pregnancy outcome, especially for long-term preventive health, really our smoke detector and identifying that risk? Or is it really a reflection of the fire and contributing to the burden of smoke? And I thank AI for generating this wonderful image for my analogy. So we wanted to ask this question and thought the New Mom to Be Heart Health study was one opportunity to try to ask this question using a causal inference mediation framework. And, I think the arrows shown here, everyone would agree with, right? BMI coming into pregnancy is associated with the risk for adverse pregnancy outcomes, and BMI is associated with the risk for postpartum CVD risk factors like hypertension, diabetes, hyperlipidemia. And we focused on the risk factors and not incident disease in this study because this cohort is still very young and our follow-up was at the 3 to 4 year mark after pregnancy. We also know that the adverse pregnancy outcomes are linked to postpartum CVD risk factors. We've talked a little bit about that, and you all see that, right? People go on to develop chronic hypertension and diabetes even in the first 5 years after their pregnancy. And so in that causal inference framework, we wanted to ask this question of, how much of what we're seeing is where someone started and where they were going already, and calling that kind of this total effect. And if we could decompose it into how much of it was directly related to that earlier BMI versus how much of it is indirectly related to the adverse pregnancy outcome occurring, if we can decompose this, understanding that, of course, this is, I think, a very complicated pathway with lots of potential confounders. So perhaps this is somewhat oversimplified. In our study, we had over 4,000 people that had enrolled at a mean age of 11 weeks. The maternal age at baseline was 27. As expected, we had a fairly high number of people with obesity, and 15% developed new onset hypertensive disorders of pregnancy. In that index first pregnancy, these were all NULLIPs coming into the study as well. You can see the associations between having new onset HDP, and we grouped gestational hypertension and preeclampsia together here for the risk of hypertension, hyperlipidemia, and diabetes. Not surprisingly, the strongest relationship is with hypertension, with the covariates suggested below. But when we looked at that total direct and mediated effect, you see that in large part that the total effect is driven by that direct effect. So the risk of hypertension, hyperlipidemia, and diabetes will increase for those people, especially for hypertension after HDP. And there's a small proportion mediated by the HDP, was largely related to the BMI coming into pregnancy. So if we have the sense that adverse pregnancy outcomes are an important marker, that they underlie preceding risk, well, where are we in terms of the current public health burden of these, and how do we understand those upstream drivers then? So if we go back to this framework, I think really briefly thinking about the pregnancy period and short-term morbidity, this is a graph and figure that I think probably is incredibly familiar to everyone here in terms of the unacceptably high rate in the US compared to other countries. I think we could have a very long conversation about whether or not how accurate 17.4 is, but regardless of the exact number, I think it's fairly well accepted that we are doing much, much worse than most other countries, especially high income countries, and that the majority of these deaths are preventable. And I think importantly, when we think about timing, that nearly a third of these are happening after that immediate postpartum period in the 43 to 365 day time range, and that many of these are cardiovascular in nature in terms of the associations or causes of death related to hypertensive disorders, to cerebrovascular accidents, to cardiomyopathy, to other cardiovascular conditions as well. When we look at the burden that precedes maternal morbidity and mortality, we see very similar patterns. We've done some work looking at the National Center for Health Statistics birth registration records and looking at the reporting for new onset hypertensive disorders of pregnancy and gestational diabetes, which are shown here. And again, very consistent patterns of increasing as well as persistent disparities, with the highest rate of new onset hypertensive disorders among individuals who self-identify as non-Hispanic Black, and the highest rate of gestational diabetes among individuals who identify as non-Hispanic Asian. As we see all of these patterns, I think one of the most common refrains that we often hear is that maternal age has increased in this interim. And so maybe that's a driver. We know there's a relative risk increase among individuals who are older and have pregnancies. And so we wanted to ask that question. Is this because of maternal age? Can we explain some of the changes that we've seen? And so first we looked at the overall records for live births between 2007 and 2019. And in this heat map, you can see that the individuals who have teenage pregnancy, so 15 to 19, have decreased, and that the overall median age has changed from 27.4 to 29.1, but largely driven by the decrease in teenage pregnancies and pretty consistent otherwise kind of ages in the, or proportions in the other groups. When we thought about this question, we wanted to say then, what is the distribution in each age group of new onset hypertensive disorders of pregnancy? So kind of taking an absolute look at a question that often gets a relative look at, where we know there is a relatively higher risk among those who are older. And when you slice up the pie this way, I think it's really interesting because we know the majority of births are happening in the 20 to 39-year-old age range, but that we see that nearly 50% of new onset cases are also happening in the 20 to 29-year-olds. And so I think really emphasizing how much of a burden is happening at an age where we're probably not picking up risk just based on age. Another way to ask this question is thinking about it using birth cohorts. And so this was a question that we thought an age period cohort analysis was an interesting way to ask this question, and say, if we plot based on age the incidence of new onset hypertensive disorders of pregnancy, again using the National Center for Health Statistics birth registration records, which has some limitations in how reporting may have changed over this time period for some of these conditions, and look at when pregnant people were born, so their generational or birth cohort changes, and then see for the same age, well, how did the risk change across birth cohorts? And you can see based on the earlier or older birth cohort to the more younger, or I don't even know, are these called millennials, Gen X, Gen Y? I've lost track, but you can see that the pattern is that for the same age, individuals who are in more recent birth cohorts have higher risk. And so I think this also suggests there are underlying changes that are occurring on a secular level that are driving some of the changes that we're seeing beyond maternal age. So as we've talked about this, I think the conversation is that we know there's increased cardiovascular disease risk. We know that there's growing burden of adverse pregnancy outcomes that sets people up for higher cardiovascular disease risk. So how do we think about changing that trajectory? And I think cardiovascular health promotion, and particularly opportunities to intervene in the peripartum period, may have the greatest benefit for us. So we've focused a lot on the right side of this diagram so far, but I want to take a little bit of time on the pre-pregnancy upstream driver perspective of cardiovascular health as well. So why does pre-pregnancy cardiovascular health matter, and how does it matter? Well, we know that the individual risk factors in cardiovascular that construct cardiovascular health, and we've talked about them in terms of hypertension, diabetes, hyperlipidemia, smoking risk, obesity, are all associated individually. But is there a composite or additive burden this has been a really important area of work in the cardiovascular literature, where we've tried to come up with scoring systems and different ways to synthesize the information over a variety of risk factors. And so we wanted to apply it to adverse pregnancy outcomes and see if we see a similar graded response. And in fact, we do. You can see that for individuals that had better cardiovascular health, shown with a higher cardiovascular health score, so all of their risk factors that were reported here were normal in terms of a normal BMI, no hypertension, no diabetes, had lower risk of having ICU admission during their delivery record, preterm birth, or a low birth weight infant. And we defined these three specifically because of what was available on the birth record, but I think many of these may also be generalizable to other adverse pregnancy outcomes, and I think that might be helpful if there's a way to score or consider health in a different way. I think the other thing that was helpful from this was that we saw kind of consistent relationships across these outcomes with worsening cardiovascular health. This isn't something that I think is that new, but perhaps it was reframing it. These are older data from the New Mom to Be study that asked this question from a blood pressure perspective. And I really like the way they set the study up, because they asked it kind of thinking about two different questions and what that interaction might be. So among individuals who were nullips, had enrolled at a mean gestational age of 12 weeks, and they had access to about 8,000 people with a blood pressure and follow-up, they said, well, if we stratify based on their enrolling blood pressure, not surprising, right? Normal blood pressure has the lowest risk of developing preeclampsia in that pregnancy. So you come in with a lower blood pressure, you're less likely to have preeclampsia. But then they stratified each group into a downward or stable trajectory or upward trajectory based on a delta in their blood pressure recording between the first visit and the second trimester visit. And so I think that's really helpful, because it says even if you come in with a normal blood pressure, if you increase, then you're going to have higher risk. And that increase was consistent whether you had normal, elevated, or stage 1 hypertension. So it's starting to suggest this idea that, your pre-pregnancy cardiovascular health matters, but what happens during that pregnancy may also identify risk in a different way. If we take a step back and think about how this applies on a broader scale, on a population scale, I think we're all very familiar in kind of the adverse trends with cardiovascular health declining in terms of obesity and severe obesity, hypertension, prediabetes, and diabetes. And this is not any different in reproductive aged individuals who are pregnancy capable. And in fact, when we look at these same factors and consider that kind of optimal cardiovascular health as a normal BMI, no hypertension or no diabetes before pregnancy, we see kind of a general trend of worsening cardiovascular health that's consistent by age. And so I think that trajectory that's changing by age may inform those birth cohort patterns that we saw earlier. And importantly, we see kind of persistent and adverse trends with lower cardiovascular health among people with adverse social determinants of health. And here we use WIC enrollment and as a surrogate for that, which of course is not perfect given that not all who are eligible enroll, but consistent declines there as well. So all of this really, I think, sets up a perfect storm where we see worsening pre-pregnancy cardiovascular risk, we see increasing adverse pregnancy outcomes, we see a growing burden of maternal morbidity and mortality, potentially, but also cardiovascular disease risk as well. And oftentimes when we're focused on that worst outcome, I think we're seeing just the snapshot of the smallest proportion of people who may be affected. And from the population health perspective, maybe a broader look to expand our focus on how do we not just identify those who have had an adverse event, but perhaps think about the health promotion aspect of it, which I don't think is just the reverse of preventing disease, but really reframing the conversation to how do we think about health throughout that peripartum period, before pregnancy, during pregnancy, and postpartum. As we think about this, it's been really nice to see these multidisciplinary and multi-society documents and organizations come together with HAACC, with ACOG, I think this focus on the reproductive years is an important life period to focus on cardiovascular health promotion. I think has been nice to see some visibility of this and think about how we can continue to push this paradigm forward. We focused a lot on the postpartum period, and this was a brief synopsis that we put together for JAMA with that cardiovascular health construct. This is an American Heart Association Life's Essential 8 is how they've branded it as a way to think about promoting health. And we highlighted the postpartum period here, but I think it applies to the entire peripartum period because it's perhaps a captive time when individuals may have access to care and may be engaged with the health system and have been used to during the pregnancy period having high levels of engagement. We see very low levels of engagement in non-pregnant people outside of the peripartum period, and so it makes it even more challenging to think about how we may address these risk factors. These 8 things that are listed here, diet, physical activity, nicotine exposure, sleep health, these 4 as health behaviors, and then the health factors, BMI, blood pressure, glucose, and lipids, form this kind of overall 8 group of things that the American Heart Association has highlighted as critical areas to focus on for long-term health, but I think apply really well here too, with of course some challenges and questions of who to screen, when to screen, how often to screen, especially for the blood work related factors. One of the things that we've thought a lot about in this space is not just that the postpartum period is the 4th trimester is an opportune time, but it may also be helpful to think of it in that life course context as it may really be an interpregnancy intervention. And are there opportunities to consider trials or other things that really could help us better understand that interpregnancy period as another critical period that could be zeroed in on, especially among individuals who may have interest in having another pregnancy. With that in mind, one of the things that we were really interested in was to synthesize some of the available data to say, if we think that interpregnancy and the risk factors that lead up to pregnancy are critical in terms of influencing cardiovascular disease risk, well, it feels like optimizing pre-pregnancy cardiovascular health, moving upstream in the life course, may have the greatest benefit. And we commissioned the scientific statement with the American Heart Association to really try to highlight this for the pregnant person as well as for their offspring. And not much time here for that discussion, but I think a really important area where we think about the influences on offspring development and childhood outcomes, thinking as well in the context of those foundational determinants in terms of how psychosocial factors, stress, resilience, social determinants, and structural policies, of course, influence these individual level health behaviors and health factors. So I wanted to kind of close out with leaving this big question on the table. So how do we do this? I don't think anyone's going to disagree that this is our goal, is we want to achieve ideal cardiovascular health for all birthing adults at any time in that reproductive life course, and of course from the population as a whole. And I really think that there's a lot of gaps, but perhaps 4 that I wanted to highlight were: first, ensuring that there's awareness. Cardiovascular disease risk, I think many times, both from the patient perspective and from the clinical perspective, we're talking about very young adults, and a lot of the risk and outcomes that we're seeing may be happening in people in their 20s and 30s. And so I think really highlighting that awareness of risk. The adverse pregnancy outcome as a risk enhancer, this increase in risk that happens after the adverse pregnancy outcome, and making sure that that's being monitored longer term. How we quantify risk and reduce risk, I think, is a key gap where we need more evidence. And of course, thinking beyond the individual in terms of assessing and addressing social determinants. A couple of key studies that I think highlight this. The American Heart Association does this national survey, usually on a 10-year basis, of asking women in the population what the leading cause of death is. And in 2009, 65% of women correctly identified heart disease as the leading cause of death, and that number declined in the last 10 years. And I'm a little bit scared to know what that will happen in this growing era of misinformation of where where that number will go moving forward. We thought this survey was a great way to be adapted to postpartum individuals and ask if after an adverse pregnancy outcome were individuals appreciating that their perceived risk of cardiovascular disease was higher than average. And in fact, similar to the survey done nationally, we saw that half of people who had had an APO correctly identified their risk as higher than average. I think a lot about the guideline perspective of how we can help inform clinicians on what should be done. It's all well and good to talk about the epidemiologic association or the potential mediations by things. And I think this is a key gap that we need to address, that we have these cardiovascular risk assessment guidelines for risk assessment with pooled cohort equations, but we start at age 40. That's far too late, I think. We talk about risk enhancing factors like hypertensive disorders of pregnancy in our guidelines, but I think we need much more awareness here. And really for young adults, we focus on 20 to 39-year-olds getting risk factor assessment every 4 to 6 years, which might be fine if there's not been an adverse pregnancy outcome or there hasn't been any perturbation, but we know that chronic hypertension can develop within the first year after an APO. And so that I think is perhaps something that needs to be modified. Starting to think on a longer scale, lifetime or 30-year risk is an area that I have a lot of interest in. Can we better assess longer term risk as we think about what we're doing and how we're communicating? And this was part of the prevent equation development that we put out that is available online that can calculate risk. We started at age 30, so I think it's still a little older than we should be thinking about for a lot of the birthing population, but it does give you 10 and 30-year risk for CVD, ASCVD, and heart failure. So I think it's a starting point. A lot of this conversation so far has been focused on individual level health factors and health behaviors, but of course, we know that upstream social determinants of health are a critical and fundamental cause of health inequity due to structural and systemic racism and are in large part the drivers of the even pre-pregnancy cardiovascular health that we've spoken about. I thought this was a really nice figure that I saw on my drive to work in one of the local hospitals here. Put this up recently this holiday season saying who gets the chance to be healthy. And I think that is how we have to think about fundamentally changing our perspective of health as a country and as a society. If we think about these all as individual level obligations, I think we're going to continue to be hitting the same walls. And I thought this was a really nice way to think about the sense that health and wellness are more than clinical and biologic factors. And this was a really nice quote from a book that I'd read recently on public health and how we think about this. And Sandra Galea, who is now the dean at WashU for their School of Public Health, wrote, "We cannot escape the fact that our well-being will never be a matter of pure self-sufficiency. It is deeply dependent on our interactions with the people around us, the people with whom we share a room in our world." And as our world gets more and more fractured, perhaps this is something that we need to come back to and think about in how we move forward. I do think there's a lot of opportunity, and when we consider birthing adults in the postpartum period, for how we can engage on that broader scale and think about the socio-ecological framework of policy level changes, particularly related to Medicaid extension and smoking bans that are in place, and more work in that area that is needed, community engaged interventions that think about non-traditional ways to deliver screening and healthcare, health system interventions, remote monitoring programs, as well as the individual or patient clinician level. I'd be remiss if I spent this entire discussion not talking about the influence of the pregnancy and peripartum period on offspring. And I think the schematic I showed earlier of adverse pregnancy outcomes leaving the cardiovascular disease is paralleled here for offspring. And knowing that if an individual starts off their life after birth based on their intrauterine environment at a higher risk of cardiovascular disease, well, we're going to see that higher risk. And so perhaps the pre-pregnancy period is just as essential for offspring. And in fact, this is something that we are currently testing as a site for the ENRICH study, which is a intervention in the pregnancy and postpartum period to promote cardiovascular health funded by NHLBI to look at this exact question and look at cardiovascular health, both in the birthing adult and the offspring. So excited to see the results of that. And we're well on our way to enrollment. And hopefully that will be something that we'll have positive results from in the coming years. So I want to conclude with some takeaways in terms of the key things that we have discussed today, thinking about really the overarching framework in the peripartum period as a window of opportunity when risk is unmasked. So I think that that question of marker, mediator, causal influence or not, it is clearly unmasking risk that exists. We have seen very, very adverse trends with population level declines, particularly in younger generations, and persistent racial and ethnic disparities that need to be addressed. And third, this overarching shift, and I think this is perhaps the most provocative thing to think about, is how do we move from this disease-based approach that we all take often to a cardiovascular health approach or a general health approach and health, wellness, well-being, and think about this on a broader societal level and public health level to achieve health equity and achieve health and wellness for all. So thank you so much for your time and attention. And I think these are very interconnected things in terms of achieving ideal pregnancy health for ideal heart health and long-term health and well-being.
Thank you, Dr. Khan. Thank you so much for that excellent lecture. I see that Dr. Sharma has her hand up.
Thank you, Dr. Khan, for this thought-provoking and just amazing talk. And this is a passion area of mine, so I'm just super, super excited. I'm Ruchira Sharma. I'm one of the maternal fetal medicine doctors here. So this is something we are trying to develop at our center, a collaborative cardio OB framework with our cardiology colleagues and a very passionate cardiology partners already. So I have a question regarding that. I think we have gotten really good overall in managing patients who have pre-existing cardiac risks, right? Patients who have pre-existing cardiac problems, we have risk stratification tools for them, and we have started to do better on them. But there is still a debate, and this was an internal debate in our division about which patients to capture and where we can really lower the risk and in a cost-effective way. So which patients are the ones where, is there a AHA guidance regarding that? Like, for example, if we take all chronic hypertensive patients in the cardio OB framework for long-term follow-up in this cardio OB clinic, should that be pre-existing, long-standing hypertension? If we take obesity, should we take only class 3 obesity because there's the HFpEF risk, or should we capture all of them? So do you have any guidance regarding that?
It's such an important question, and I think this is probably one of the areas where we have a lot of opportunity for trying to establish some frameworks, and I think best practice. That's right. We often see that across these programs, and we have a cardio obstetrics program as well that is led by one of our faculty, Marla Mendelson, and one of my mentees, Priya Frani, is building out a chronic hypertension clinic, just Ruchira, like you said, because we're seeing a lot of need. And I think the challenge is it's not clear because we don't have data to say it's going to be most effective or most cost effective in certain subgroups. So there's a lot of personalization at each center that's happening. I think the other piece that, I didn't spend a lot of time on today, but is a growing area in the American Heart Association framework is considering the cardiovascular kidney metabolic spectrum together. And so that may be a way that we could provide some additional kind of thought around who's the highest risk and how do we consider that longer term. But for now, I think it is really around like, how do you gauge how much bandwidth you have? Because for us, the other issue is how many cardiologists do you have that can take that on? How many primary care clinicians do you have? We have huge shortages and challenges getting people in. So our prioritization has not been, I think, based on who would benefit, but who are the highest risk so that we can get them in. So I think ongoing conversation needed and definitely data on saying, how do we best identify who is going to benefit?
Thank you so much. And I have another follow-up. I'm so sorry to take to take more time. But regarding obesity, so obesity, are you capturing more of the HFpEF population in class 3s and super obesity, or you're also seeing that in lower categories?
Yeah, I think we're seeing a lot of risk in lower categories as well. I think one of the advantages of capturing class 3 obesity is the potential for treatment and I think change in the ability to use GLP-1 RAs to help lower risk. And that's where I do think a lot more people are considering referrals, whether it's weight management programs within primary care or other long-term practice for how to reduce that risk. So I think we haven't used a BMI cut point for our referral program, but I think there's opportunity, especially with growing cardiometabolic programs that are trying to catch that risk as well.
I see that Dr. Ananth has his hand up.
Thank you, Dr. Ebert. But before I ask my question, I would ask Dr. Rosen to ask his question first. I think that's a more interesting question. So, Dr. Rosen, please go ahead.
Dr. Khan, thank you for your talk. I hope my question is interesting. I didn't hear this in your talk, and I've never looked at this myself, but is there data that suggests that pregnancy by itself, even if there's not an prenatal adverse outcome, is a risk factor for cardiovascular disease later in life?
It's a really interesting question. We've talked a lot about this philosophically because the decision to become pregnant or not pregnant, I don't know if you want to necessarily state the risk itself from it. But in terms of multiparity, that's where there's probably the best evidence. So if you have 5 or more pregnancies, then there is higher cardiovascular disease risk. I think the question of how to answer that question when there are so many structural, personal, family-based reasons for why someone may or may not become pregnant is really challenging. But of course, I think are nice physiologic studies that show structural changes during the pregnancy that occur, but are believed to revert. So I don't have an answer. I think if someone else knows of better data, I think a lot of the available observational data are confounded in how to answer that question.
Yeah, Dr. Khan, just a comment, and then I'll leave you alone. It's sad, like we know the link between pregnancy, which protects against some conditions, for example, ovarian cancer. We know it, at least for 10 years, it will increase your risk for breast cancer. It certainly increases the risk for pelvic floor damage over women who've never been pregnant, whether they deliver vaginally or by C-section. But it almost sounds like you want to take a don't ask, don't tell approach to that. Like you sound like you don't want to know me. I'm sorry, I'm not, like, do we want it? It's not great for the human race if women decide not to get pregnant ever because they know they're at a greater risk for mortality or injury. So I'm not sure if it's a question that we need to answer, but it sounds like you might not want to answer the question. Am I completely misreading what you said?
Oh, no, I think that was more of a comment. I think we should answer questions if we think that they may have important conclusions. I don't know if there's a great way to answer this question.
Thank you.
Dr. Ananth, was that your question?
No, actually, Dr. Rosen and I have been texting, listening to this talk, and we were deciding who's going to ask this question. We both had the same question on our lists. So anyway, thank you. Thank you, Dr. Khan. This was a fascinating talk. Every time I listen to this talk, and I've heard a sort of a different version before from you, there's always very, very nice learning pearls from your presentation. And I will admit, I'm almost bordering jealousy looking at the work you're doing and the fantastic contributions you've been making. But besides that, my question from your presentation is, can you articulate to us the impact of treating obstetrical complications and how that might mitigate cardiovascular risks? So in particular, I'm talking about, there's almost a doubling in the risk of CVD along the life course when persons have preeclampsia in their pregnancy. So if you were to treat them with aspirin, which is a huge, huge benefit for both treating preeclampsia as well as cardiovascular outcomes, what is the association there? How much of a reduction do we see in treating patients with medications for obstetrical complications?
Yeah. Well, first, ditto. I think we're in the mutual admiration fan club. So I think I'd love to spend, 30 minutes talking about your paper, considering the changes in maternal mortality and some of the other work you've done in causal inference. So I'm sure you could take apart the paper I presented on that. So, but we could get to that later. I think your question's a really, really important one where we need more data. I will say from the cardiovascular perspective, there is this unbelievable bias in doing trials where there's hard events. There's like this, fascination with needing hard cardiovascular disease outcomes in order for a trial to be done and for an understanding of whether or not there's benefit from a therapy. And it hampers evidence generation in this young group where we're talking about really low event rates. And so to power something like that, you need 100,000 people or something unbelievable to do this in a prospective clinical trial. I think observational data can help us, but there's a lot of challenges in data capture of who's taking aspirin. Did they take aspirin with good adherence, and did that influence their cardiovascular outcomes? But I think that's a really important area. The other comment I'll make is on the cardiovascular side, aspirin has totally fallen out of favor for primary prevention. And that is also a challenge because I think in these individuals where there is a benefit for preeclampsia, it feels plausible that there would be a benefit in extending aspirin. We just don't have the data.
Thank you. We should set up a time later and talk more at leisure.
I would love to. Yeah.
Yeah, thank you.
All right. Well, if there are no further questions, then I would just like to say thank you again, Dr. Khan, for this excellent talk.
Thank you so much for the invitation, and I really appreciate the conversation and discussion.
Thank you. All right, well, we're going to end it here. Just so everyone remembers, this is the last resident interview day of the year, so the residents will return to the floor at 1:30. I thank you all for your attention this morning, and I hope you all have a safe and productive day.
Dr. Khan, just hoping you could stay on after everybody hops off for 5 minutes.
Oh, for sure.
Dr. Ebert, if you need to stay on, you're more than welcome to, so the meeting doesn't get shut down.
No, I'll make you the host.
Can you do me just a favor and kick out anybody who might have walked away from their laptop?
Sure.
Thank you. Slowly but surely.
Yeah, no, you're right. It's, people walk away and then it's so hard. I love Scrabble picture though. I love Scrabble.
It was a pandemic purchase that
That's awesome.
that now is a to-do sticky board.
That's awesome. I want that. That's so cool.
So let me introduce myself. I'm Archana Pradhan. I am stepping into the role of interim chair of the department January 1.
Oh, awesome.
And
Congratulations.
thanks. Your talk was amazing
Well, thank you.
on so many levels. I actually texted Gary during it. I'm like, do we have our slide deck? I think the point that Ananth was making about there's all these pearls in there and we need to make sure that we are actually incorporating those into clinical practice, right? And so the other piece, besides stepping into this interim chair role, is I'm also doing ELAM this year.
Oh,
So
nice. I've been like, it's been on my like radar. I just haven't yet gotten like
it's
my
amazing.
activation energy to do it. Yes.
It's amazing. I mean, it's a ton of work. I'm not gonna lie, but it's fabulous. And so yeah, as part of ELAM, you have to do an institutional action project. And so my institutional action project, as I promised the dean, is to get a cardio OB program running.
Yeah.
And I'm wondering, do you have one at your institution? Do you know, does anybody have one? Structurally, how does that get, thoughts?
Yeah, no, for sure. So Marla Mendelson is the person that's been running ours. We've had it probably for a couple of decades, and I think Ruchira's point was a really good one in that most people start with the overt cardiovascular disease. And I spent a lot of time talking about, so I'm a preventive cardiologist. I'm like, once they have disease, I'm like, go to the other people that take care of people with heart failure and have had an MI,
Yeah.
mostly. But I think that population is the high, that is, coming into the pregnancy with disease or has an event during the pregnancy in terms of MI, heart failure, stroke, feel like the highest yield when you're getting started. The other piece I've seen a lot of places do is do the blood pressure piece. Because I think a lot of the challenge in this area is like, what should cardiology own? What should primary care own? So there's
Yeah.
definitely tension there in terms of
Right.
where people are transitioning. And then also like, is there bandwidth within your cardiovascular division to take on lower risk people?
Yeah. It's funny that, Rushira comes to it. She was so excited by your talk. I could like hear it in her voice. So comes to it from obviously she's an MFM. So it, comes to it from
Yeah,
that perspective. But we've been talking about this should be not just for kind of from your end, we actually should be thinking about it from the preventive, from the preconceptional time period, whether you have heart disease or you don't have heart disease. And so and we actually have a health system that that is embracing cardiovascular health in women as one of their big pieces of how do we connect all the cardiologists that are part of our system and connect them into the women's health. So when you have somebody with disease, how do you get them into obstetric care? For us, when they're there for a GYN visit and we identify something, how do we get them into a cardiologist, right? So, and we're having a hard time kind of wrapping our heads around like, where do we start with this? Do we start little and go big, or do
yeah,
we go big and the other way?
yeah.
So,
And I think, yeah, I guess one of the other questions would be perhaps it may be rather than like what's optimal, perhaps what is practical, like how many new appointments can your primary care health
mm,
system take and in
right,
what temporal period, and then
yeah,
how many new appointments can cardiology take. The thing that has been the most productive that I've seen across programs is if there's a designated person in primary care or in cardiology that will take ownership so
yeah,
that they have blocked spots because
yeah,
like right you don't know when people deliver
yes,
and blocked spots are very hard to come by. No health system wants to do it, but if
yeah,
there's a commitment to blocking them, we filled them. Like we will show over and over again the hesitation about blocking spots, they will get filled. Like there's just so much, especially if you go broad, like any preeclampsia. We've kept our hypertension clinic to preeclampsia with severe features and saying
yeah,
that we want to get people in within 12 weeks after a pregnancy with preeclampsia with severe features, and we're filling them. There's so many people, and I'm sure you see this, right? Like that have that so that they're not getting dropped in terms of like after the
yeah,
acute care is over, because like there's great care until their blood pressure is better, and then it probably spikes again, and we just aren't seeing it.
right. Do you have a protocol in place that's, kind of that you've shared out through your system to say, here's what we want it
Yeah,
to be?
So definitely for the blood pressure, because we've protocolized that clinic Priya Freeney, and I'm happy to connect you with her as well, because I know she's chatted a lot with Malamo Contreras and Elise Hasberg, who was at Pitt and now is at Brown, I think,
Yeah.
just moved to Brown. Have done a lot of this at Pitt and really focused on blood pressure there. And I think that is it's maybe not like I think people with CVD should absolutely be in cardio OB programs, but I think they generally get to a cardiologist somehow. I think the blood pressure piece, it's a bigger scope, but it maybe have a bigger impact from a prevention standpoint. But thinking about what's the bandwidth, I think will help answer like how big can you go? Can you go?
Yeah, we have a great, you may know her in your, so Rachni Kulkarni, she was the president of the AHA last year. I think that was what, yeah, do you know her?
Okay.
She's,
I don't.
well, anyway,
What?
she's like a VP of cardiology in our health system who's a big so I think she's in. So I like the thought about just having them identify before we build, what do you actually have the capability to take?
And who's interested? Because I think getting buy-in from the each, like whether it's primary care and maybe it's both, and it's primary care has certain people that they'll see because they should see,
Yeah.
anyone who's transitioning, and then cardiology can see the highest risk people, and we can create an algorithm for that. There's several that exist. It is very inconsistent across places, and then I think the other question is, do you do this as a QI thing and track it, or do you do it as a registry? And we've operationalized it as a registry as well. And so I think I got your email. I am happy to connect you with Priya, who has been leading our effort. I think multi-center approaches to some of this could also be just really beneficial and productive for all of us.
Yeah, I was thinking, if you guys want to start up in projects that you're working on that you're like, oh, these people could plug in for that. And we have an Anth on board to
Yeah,
do all kinds of stuff with us. It would be
yeah,
amazing.
yeah.
All right.
I
Well,
think
thank
there's a
you.
lot of opportunity.
I don't want to keep you any longer. I'm sure you have other
No,
things on your agenda. Hope
no,
we will be in touch. If you could connect me with
yeah,
people who are doing this, I feel like I'm coming. I've been in the education space for the med ed UME space. So I'm coming from being the associate dean for clinical education back into the department. So I feel like I'm getting my bearings again,
yeah.
and making
Oh, that's
sure.
awesome.
Yeah, absolutely. Well, thank you
Yeah.
again.
Oh, for sure. No, it was wonderful to meet you, and I'm looking forward to following up as well.
Okay, awesome. Take care.
Amazing. Take care. Thank you so much. Have a great day. Happy holidays.
You too.
Bye.